Okay, so I think we'll get started. I have some questions already. So a couple things here before we get started. If you have a question regarding the actual webinar and the content, type that into the Q&A feature. If you just want to make a general statement or comment about the sound or technical problem or what have you, type that into the chat box function. That's how I kind of look at things. If that's okay. Now, today's lecture webinar is on arthritis. I actually specifically didn't say what type of arthritis, but to be honest, it's really focused more on osteoarthritis, although basically what I'm talking about can be applicable to both osteoarthritis and say rheumatoid arthritis, but I'm going to talk a little bit more about the etiology and some of the pathophysiology, more in reference to osteoarthritis. Just because I don't have the time to get into RA as well. But you can also use it successfully for RA. And in fact, I might actually do that as a separate webinar as well. So just so everyone's aware, the webinars are always recorded and we edit them after we've done them. And then we send out a link in order for you to watch it again, or if you have to leave early, or perhaps you registered and you weren't able to actually listen in and you want to watch it. That's always an option, but you do have to register for that so that we have you on the email list in order to contact you as well. So today's topic I mentioned is arthritis. And you know, this is probably one of the most common things that we treat here in our clinic in Toronto. And I'm sure as a practitioner out there, and I do 2 streams of webinars. Today's webinar is geared more towards healthcare professionals, but anyone can obviously listen in. I'm actually doing one on knee osteoarthritis coming up for more for the general public and the home systems. But regardless, today's is geared a little bit more towards healthcare professionals and maybe ones that actually have our system as well. But most of the information is applicable regardless of what kind of system that you might have. So I will talk a little bit about the anatomy and etiology of arthritis. And specifically, I'll get into why we have the symptoms, why your patients have these symptoms, and sort of how laser therapy or photobiomodulation can be really helpful in managing this type of condition. And I will present a couple of papers. There's actually a lot of research on arthritis and photobiomodulation. I just chose a couple of papers that I thought were interesting, but there's a lot of specific papers on that. I'm getting a really unusual black spot on my screen. I don't know if everyone sees that or not. I'm not sure what that's about, but anyway, maybe it's because I'm in Machu Picchu today that is giving me a problem. And then I'll, of course, talk a bit about BioFlex and how you would approach treatment and treatment plans, that kind of thing. I think you should find that useful. And of course, time for Q&A. So ask questions along the way. I just won't get to those questions until the very end as well. Okay, so obviously anatomy-wise, when you're dealing with arthritis, we're interested in treating very specific structures around a joint. Obviously, the articular cartilage, the hyaline cartilage, is problematic because it degrades over time due to arthritis and wear and tear. So that's one target tissue. And of course, synovial membrane would be another target tissue as well. I didn't list on here, but other target tissues would be muscles, surrounding muscles as well. So when you use laser therapy, you should be targeting, you know, anything that's symptomatic. And of course, with laser therapy, you're also trying to achieve not just symptom relief, you're actually trying to heal or help tissues improve their integrity. So what I mean by that is you're not going to, you know, restore hyaline cartilage pre-symptoms of arthritis, but you actually can help to rebuild cartilage depending on the state of the arthritis. And there's lots of research to show that. And this isn't me just kind of, you know, flopping at the gums here. There's actually good research to show that. And actually, there's one human trial, I didn't present it today, that actually shows that on radiographical changes or imaging changes, that hyaline cartilage can improve, regrow, you might say. So that's really important as well. Obviously, osteoarthritis involves damage to the cartilage and even the bone, the subchondral bone. That's the bone around the cartilage. A big contributing factor to symptoms and inflammation is the synovial lining and the synovial capsule. And so this plays a key role in the ongoing progression and degradation of the joint with arthritis. So in early osteoarthritis, it's characterized by the infiltration of mononuclear, which is a type of white blood cell production. And these lead to an increase of what's referred to as pro-inflammatory cytokines. And this is a chemical mediator secreted by white blood cells that leads to damaging of the cartilage. So it's a progressive condition over time that, of course, causes joint destruction and symptoms and all the things that we know our patients suffer from, and maybe even you do as well too. You know, I'm well into my 50s now, and I definitely have some wear and tear and signs of osteoarthritis. And in particular, I had an interphalangeal joint that just flared up. I don't know, have no idea why. And yeah, I'd never had it that severe before. It was really weird in the sense that it's like, oh, wow, like it's really flared up. And so I've been treating obviously with laser, and it's definitely very helpful. But it's just such a common problem. So obviously it's good to understand how laser therapy is going to help. Now, synovial inflammation is an important source of both pro and anti-inflammatory mediators. Now, there are specific interleukins. It's a form of cytokine, specifically interleukin-1 beta and interleukin-6. There's a few others as well. These are secreted in higher concentrations by the inner cell lining membrane of the synovial membrane called synovial cells. And this induces and causes a cascade of degradation, and this will lead to the joint injury. So now, you know, I'm not going to go into, although I'm showing you some real detail here, I'm not going to really expand on it, other than I want everyone to understand that when you look at the research and understand how laser therapy is going to help, it works at this level. And it works at the level of the pro-inflammatory and anti-inflammatory mediators that I've already kind of mentioned to you. So you can see the pro-inflammatory mediators, there's certain cytokines, metalloproteinases, that's been well researched, certain neuropeptides, nitric oxide. There's a whole bunch of different interesting molecules that cause problems. And then there's the good guys, the anti-inflammatory mediators. And these are the ones that you want to shift the balance, so it's more towards the anti-inflammatory than the pro-inflammatory. So certain cytokines as well. You know, IL-4, IL-13, and so forth. These are the ones that you want to shift towards increasing in order to help the symptoms as well. So if you look at a cross section of a joint, you can see the blue area, that's normal articular cartilage. This would be the early stage kind of cross section. You can see the yellow is the synovial fluid. And then next, as you go out, so you're going from in to out, right? So you would meet up with the cell lining of the synovial membrane. Now, these cell membrane, the synovial sites, you see you get an infiltration of these white blood cells that creep in, and then they start to cause problems. And that's when you start to see these release of these inflammatory mediators into the synovial fluid. And of course, it makes its way to hyaline cartilage and the subchondral bone. And over time, it causes joint degradation. Now, this is a little bit more detail, and again, I'm not going to really expand on it, but if you look at a chondrocyte cell, it's embedded in a network of collagen fibers and what's something referred to as aggrecan. And there's a specific enzyme called ICE, or interleukin converting enzyme, and it activates a very specific interleukin 1 beta. And this causes the expression of what are referred to as metallo matrix proteinases, and this degrades the matrix components of the cells and the tissues, and starts to cause problems. Another enzyme is COX-2. You may have heard of COX before. There are certain medications that are COX inhibitors, for example. It's an enzyme that increases the production of prostaglandins. Now, prostaglandins are an inflammatory, pro-inflammatory chemical, and this leads to increased inflammation and swelling and pain. So generally speaking, when you have joint swelling and joint pain in your body, you're going to see an increase in prostaglandins. It's been shown quite conclusively that photobiomodulation reduces prostaglandin formation, so that's obviously a good thing. Now, what are the effects of photobiomodulation or laser therapy? Now, in mitochondria, when they're stressed, that is undergoing, secondary effects of inflammation, there's an increase in nitric oxide. And I've talked about this before in many of my webinars. This nitric oxide inhibits aerobic respiration through the electron transport chain, specifically an enzyme, cytochrome C oxidase. And this eventually leads to the reduction of mitochondrial ATP, which is the energy source for the cell. So what happens is, as the cell has less energy to function, certain things go on in the cell, the trickle-down effects, and over a period of time, these cells can undergo cellular apoptosis, which is cellular death. So that's not a good thing. So this is definitely not a great thing to have. Now, when exposed to light, a very specific wavelengths and dosaging, the light can actually reverse this nitric oxide effect. It displaces nitric oxide, allows oxygen to bind back on, and eventually causes ATP production to increase. And this will lead to downstream metabolic effects that eventually leads to reduction in inflammation markers. The reason why I mention this is it's really important to understand is that when you're treating arthritis, you're not usually going to have a dramatic result really quickly. You may, but it's not due to this mechanism. This mechanism takes time. How long is hard to say. Days, weeks, perhaps, before you really start to see the anti-inflammatory effect kick in. But you can, some patients feel really good right after the first treatment, even a few sessions, and that's usually due more to other mechanisms like endorphins and enkephalins, blocked nociceptors, that kind of thing. And that's great, but you have to inform your patient that this is not, well, it's great, it's not actually tackling the source of the problem. So that's important to understand. And this is a reference you can see here by Jan Bjordal, quite a well-known researcher in the field. Laser therapy can help with pain reduction or analgesic effect, which is great. As I mentioned, it can disrupt fast axonal transport, these pain receptors and nerves, and it can in fact cause reversible temporary inhibition of pain. Chronic pain can lead to central sensitization. You know, it's interesting. I have a friend that has tinnitus and really bad. And I don't know all the mechanisms of tinnitus, and there's also different causes and everything, but chronic tinnitus, I think there's an understanding that it might be because of central sensitization of the cochlear nerve, that kind of thing. So, you know, one way of tackling a chronic scenario like that is to try to reduce this sort of ongoing stimulation of the nerve, whether it's pain or, you know, hearing. And laser therapy has in fact been known to be helpful for treating chronic pain, even chronic pain of arthritis as well. So sometimes patients have pain because of arthritis, but it's more severe than it really should be. And that's this chronic sensitization that I was talking about. Different ways of tackling that as well too, obviously. Time frame wise, if you look at the effects of laser therapy, Usually you're going to start to see something within 24 hours, but not necessarily. Um, and then what happens is you'll start to see the effects on the inflammatory markers. I've talked about a few of these already, COX-2, prostaglandins, and so forth. But over time, you'll start to see effects on the different affected cells and tissues. And this can lead to reduction of edema, increased blood flow, reduction of, I mentioned, cellular apoptosis or cellular death, which is just a way of saying that the integrity of the cells, like cartilage cells, less of them are likely to keel over and die, which is which is a good thing, right? You want those to regenerate. So these are all the things that are actually going on as you start to treat your patient. A little bit of research. I'm just going to present two papers. I don't have the time to go into any more depth than that. This particular one, I thought it was really quite good. It was looking at the effects of laser therapy on the expression of inflammatory mediators on neutrophils, a type of white blood cell, and macrophages in acute joint inflammation. So they looked at an arthritis model, osteoarthritis model in the cartilage of rat knees. So that's what they did. These knees of the rats received 4 joules of energy. Remember that 4 joules, by the way, because this will come back. I'll mention about the importance of 4 joules. They used near infrared, about 8-10 nanometers, which is in that range that you want to use. I know some manufacturers use 904, 905, 980. There can be some merit to 904, 905 for sure. But the wavelength that targets the photoacceptor that's known to cause all the positive effects works best in 780 to 830, 840, and that's proven science. So so I throw that out there. So on the left is a picture scan in 3-dimensional showing the nice, smooth, articular cartilage on the rat femur. And then they used enzymes to degrade it and to, present it like arthritis, osteoarthritis. So this is what a patient would look like, by the way, if they had moderate to severe arthritis, osteoarthritis, in, say, in their knee joint. The hyaline cartilage is degraded or pockmarked. You can see that. So less cushioning, more wear and tear. Of course, you get pain and stiffness and all the other symptoms associated with that. So what they found was that there was a significant reduction in the inflammatory cells in the synovial fluid. There was a larger, no, I should have mentioned, I should go back here actually, let me go back. They did 4 joules of energy. They delivered it with either 50 milliwatts for 80 seconds or 100 milliwatts for 40 seconds. Okay, so they used 50 milliwatts and they also doubled that in half the time. And I get a lot of discussion, I'm going to say that very nicely, about other manufacturers using a lot of power. And it always comes out that more power, they claim more power is better, does a job quicker, you can see more patients, that kind of talk. And most practitioners love the idea of less time. But the reality is that we're not talking about an adjustment. The chiropractor takes half a second to do an adjustment. So it takes a certain amount of time, but it's quick. Photobiomodulation, it's well established that treating for longer periods of time actually is more beneficial than higher powers for shorter periods of time. I'm not going to argue the point because that's what the research shows and all the clinical trials show. So in this particular paper, they found that there was a larger reduction in macrophages at the 50 milliwatts compared to the 100 milliwatts. And overall, with reductions of the pro-inflammatory mediators that I've talked about already, were found with 50 milliwatts being better than 100 milliwatts. So the takeaway here is, number one, laser therapy is very helpful in reducing the pro-inflammatory mediators that can cause symptoms of arthritis. But treating longer with lower amount of energy, it gave a better effect, right? And that's my point. And that's a takeaway that I think everyone needs to understand, whether or not you're going to believe me or not. I mean, there's anti-vaxxers out there, and hey, you go to town. But I do like to present the science and the research as it is. Last paper, you can tell that I'm not an anti-vaxxer. Maybe, okay, I'm not going to go on about that. So the next paper is specifically about knee osteoarthritis and whether or not treatment of moderate to severe arthritis of the knee, if that can actually postpone or prevent the need for joint replacement. I thought this was a really good randomized control trial. Well, as a prospective randomized cohort study over a period of time, they looked at 100 patients. They were elderly. They all had bilateral symptomatic knee arthritis. They took x-rays, they verified this and so forth. And they are either treated with conventional physical therapy or with conventional laser therapy and low-level laser therapy. They used, again, near-infrared wavelength, 810. And you can see the energy density there as well, and the power density. So look at the treatment plan. 3 sessions, 12 consecutive weeks. Okay, so when you're dealing with moderate to severe arthritis, you had better make sure the patient's there for the long term, because you're going to waste everyone's time if you think you're going to get this really a lot better in a very short time frame. You need to be patient. The patient needs to understand what you're trying to do and have them, sign up accordingly. Each treatment point session was 180 seconds per point. So that's a lot of time. That's because the power is quite low. So they did a follow-up after 6 years, and they showed that patients clearly benefited from the protocol B, which is the laser therapy, and only 1 knee needed joint replacement surgery, while in the protocol A, which was just physiotherapy, 9 patients required knee replacement surgery. So, that's phenomenal when you think about it. So obviously they conclude that low-level laser therapy should be incorporated into standard conservative treatment protocol for symptomatic knee osteoarthritis. Okay, let's get a little bit into now treatment. Now we treat two ways with our equipment. The first is using a BioFlex dual array. The idea here, now I'm using the knee as an example, but it's anywhere in the body that you're treating. You want to treat circumferentially around the entire knee joint. So with the knee, you're going to use 3 placements typically, medial or anteromedial, anterolateral, and popliteal or posterior aspect of the knee joint. This will allow you to treat the entire synovial membrane and capsule around the joint itself. Now, when you're targeting the hyaline cartilage, this is where you're going to be using the laser probe, which is a class 3B laser probe. You want to try and get the knee in an open pack position. If you're not familiar with that, review that. It's important to understand that because that allows light to penetrate inside the joint cavity as optimally as possible to target the hyaline cartilage and the deep structures and subchondral bone. So if you're treating like the knee joint, and again, this isn't just for the knee, this is for any area, but I'm talking about the knee joint specifically, treat all the hyaline cartilage surfaces. So not just the femoral condyles, you also want to treat the patellofemoral joint surfaces as well too. So you're going to treat all the way around the under surfaces of the patella to reach that cartilage as well. So when you're treating the knee, you're going to treat around the joint line, around the femoral condyles, and around the patella and the patellar joint surfaces as well. The standard laser probe used by most of you, or if you're not familiar with our equipment, is called the LDI 200. It's rounded off. It's actually 180 milliwatts of power. Wavelength is around 830, 825. Surface area is quite small, 0.1 centimeter squared, which means it has a pretty high energy density and power density. So the depth of penetration, and again, this can be a whole different topic, but you're looking at roughly 3 to 5 centimeters, maybe a little bit deeper, depending on how it's used and so forth, but certainly deep enough to be able to get into the joint cavity for most joints. Hip joints, definitely the most challenging, but all the other joints, it's pretty easy to do this. Now, what I'm going to recommend is that you try and achieve in and around 3 to 4 joules per point. It's pretty easy calculation. One joule for the LDI 200 at 100% power is at 0.18 watts. If you want 4 joules, then you're going to hold it for about 22 seconds per point. And the reason why 4 joules seems to be the sweet spot is that's kind of what the research has indicated. So now, of course, a knee joint's different than an elbow joint or finger joint or hip joint. So you need to kind of play around with the joules per point. But as a starting point for most sort of mid-sized, average-sized joints, I would ask you to try and irradiate and hold for about 20 seconds or so. That will achieve 4 joules. Of course, if you lower the percent power, you need to hold it for a little bit longer to achieve that. And then if you're treating big joints, deeper joints, people that are more muscular, you may want to increase the energy point such that you increase the time to even 30 seconds, 40 seconds. For hip joint, for example, big shoulder joint, that kind of thing as well. So the target is around 4 joules. And as I mentioned, larger, smaller joints, you need to adjust it up or down accordingly. Now, the array placement, these large surface arrays, a dual array, these are meant to target more the superficial structures and tissues around the joint. So the idea behind this is that longer treatment time. So this array sits on the joint for upwards of 10, 12 minutes, which sounds like a lot of time. It is, but it's hands-free. So you don't have to sit there and babysit or do something with your patient. You can do other things. And during this time, you're stimulating white blood cells in the area. This is really important because it's the white blood cells that achieve the anti-inflammatory effect. If you just hold a probe for 10, 20, 30 seconds, you're not affecting as many white blood cells. I mean, it makes sense, right? Because white blood cells are circulating in the blood, and of course, they're roaming around in the tissues as well, but they're not usually stationary. So if you want to treat as many of these white blood cells as possible and promote this anti-inflammatory effect, you want to treat longer. As well, you're treating superficial nociceptors around the knee, and this also helps with pain reduction as well. So make sure the array is secured nice and firmly. You can use a strap or you can use one of the weight systems, but it has to make good contact with the skin as best as possible. You don't want it loose on there. You want to try and make firm contact with the skin. Make sure the skin is free of creams, lotions, anything that can interfere with absorption of the light or be itself adhere to your equipment and cause problems down the line. So mention that in to your patient if they put on any recent, because sometimes you might use a cream or a lotion, or even sometimes people put on a medicated cream, right? So make sure that the area is free of all that as well. Always treat the joint circumferentially, as I mentioned earlier, all the way around the joint. That's really important. And as far as what protocol to choose, well, you just choose the anatomical protocol for that area. So if I have osteoarthritis in the finger joints, I'm going to use the hand protocol. And, obviously it goes from there. Treatment plan wise, okay, you have to be patient and you have to explain to your patient what they're dealing with. I'm sure they know, but you need to kind of explain what your goal is. Your goal isn't just to block pain. If they just want pain blocked temporarily, why don't you go and take some medication and destroy your liver and call it a day, right? This is not what we're about. Now, that might be part of the strategy. They occasionally might need medication, but the whole point of this treatment is to reduce medication, reduce liver damage, reduce all that kind of stuff, right? So it's a chronic progressive disorder disease. You're not going to cure it, but you can help manage it along with other things as well. If a patient presents with an acute flare-up, so they've come in, they're hobbling around, or their joint is red and swollen and so forth, then start with the lowest parameters of stage 1. I'm going to give an example of that shortly. Now, if the patient presents more kind of chronically with chronic symptoms, not as acute, mild to moderate symptoms, then you can start a little bit higher in the stage 1. You can customize mid-level, mid-stage 1. That's fine as well too. So you're going to start off with treat daily for a week, especially if it's an acute presentation. If it's chronic, maybe you can go alternating days. That's okay. But acute, definitely get in there and treat every day, at least 3, 4, 5 days. The first week is very beneficial to do that. Once you're starting to improve, then you can go to alternate days, so about 3 times a week. And then as they're sort of really improving, you can go to once to twice a week. And then once they reach sort of maximal recovery, you've tried different things and that's as good as they're going to get, which hopefully is acceptable. That's when you need to talk a bit about coming in for maintenance treatment. Now, don't forget, you're going to be doing other things, right? You might do hydrotherapy, you might do exercises, other modalities, other treatments, whatever. So that should all be part of the big picture as well. It's not usually treated in isolation, and exercise, generally speaking, is good. The rule, the guideline is that if a patient becomes symptomatic after they do their exercise, but it goes away after an hour or 2 or 3 hours, that's okay. So make sure you educate your patient that they can do things as long as they're not aggravating it for long term. If it's sore and it continues to be sore the next day and a few days later, they've overdone it. So you don't want to recommend not doing anything, but on the other hand, there's a balance there as how much they can do. So a few hours or so of aggravation, then it goes back to baseline, that's okay. But more than that, then they need to scale it back a little bit. So once they have achieved sort of maximal recovery, then you're looking at doing a maintenance kind of program. So when you're treating, make sure you increase the parameters in the stages as the patient plateaus. So in other words, if the patient's responding well, keep it at that level. If they're plateauing, then tweak up the parameters. Eventually, you might get to a point where you're just not making much of a difference anymore, and that's the maximal recovery. And it's hard to say where that's going to be, but of course, you're going to be doing a visual analog scale and maybe some other scales as well, so the patient can see visually what they were when they came in, what they were at week 1, week 2, week 6, week 8, and then they can visually see that. It's a bit more objective that way. Now, maintenance treatment is tricky for me to say specifically what to do because it depends on your patient. It may be once a month, it may be several times a month to maintain it, but I don't recommend them just leaving it alone until it gets really bad again, an acute flare-up. You want to provide ongoing stimulation. One thing I do recommend is a patient can get a personal therapy system, a home system to treat at home on an ongoing basis, and then come into the clinic to get laser probe treatment as well. That targets more the hyaline cartilage. So the best of both worlds. They're still your patients, they're still coming in, they're still getting treatment. And sometimes you can even do a full-blown treatment on them, but they're also receiving ongoing therapy as well at home. So that might be an option as well. So as I mentioned earlier, if you're looking at, say, stage 1, this is just a generic protocol. You can see stage 1 for the infrared starts at 10 hertz and 20% duty cycle. That's what I mean by the low end of stage 1. And that's where you're going to start for acute flare-up. But if they're coming in and they're kind of like chronic, not too bad, then you might want to tweak it up. go from 10 to maybe 20 or 30 pulses per second. And instead of 20% duty cycle, maybe 30 or 40% duty cycle. So that is mid-level stage 1. And then if they plateau, they can go up to 50, 70 for stage 1. And that's the same thing for stage 2. You can see that there's a range there. Start at the lower range, make your way up to the highest range, and same thing for stage 3 as well. So I think that's pretty clear. So the big picture here is that understand that laser therapy does follow a biphasic dose response. Too little is not going to provide you with or the patient with enough stimulation to cause any result. Too much, you don't see a result as well. So if you start low, then generally speaking, if the patient's not responding, you need to go up. If you start too high, you're not quite sure where to go. So always start as low as possible if it makes sense. So ensure that your treatment has enough doses to actually stimulate, but not inhibit. Generally speaking, our protocols aren't going to inhibit. They're designed not to do that. So and the dosaging should not inhibit. But you do always need to use what the best dosage is for that patient. And you can adjust treatment time, you can adjust power, all of that. You can do that through customizing. If you're not sure how to customize, presumably you've been trained. If you haven't been trained, take the training course. But if you want to revisit that webinar on customization, then let me know and I can send that webinar out to you as well. Okay, that's the webinar. Hopefully you got a few things out of that. I do appreciate your time. Don't forget, we do advanced certification training as well. I've decided to extend the early bird for the next advanced training, which is on the cervical spine. The guest speakers are Dr. Ben Ewan from Halifax, the perennial Dr. Ewan, who just does an outstanding job on his lectures and gets such tremendous positive reviews. If you've never heard him speak, you'll be blown away with the knowledge and how he transmits that knowledge to you. So hopefully you can tune in for that. So just go to our website under events and you can find the advanced certification training for cervical spine. Slava Kim, our clinical director, and Nathan, Dr. Nathan Chung as well will be speaking, and I suppose I'll say a few words as well. So that's on September the 18th on a Saturday. It's 4 hours. So hopefully you can join me. Make sure you take advantage of it because I extended it to August 31st, but after that point, it will go back to the full price. I believe the early bird is $229, which for 4 hours is not bad. And it will be CE accredited depending where you're from. And again, I mentioned about the basic certification training. If you're interested in that, the next one is next Friday on August the 20th. And you can register for that on Eventbrite as well, too. And we have those once a month. And hopefully one day we'll do in-person live trainings again. We're hoping to get out to Calgary and Vancouver, maybe this year, but certainly next year, as well as back in Toronto as well. Thanks again for listening.